Hi guys, today we are going to learn about intestinal amoebiasis. Learning objectives: introduction, morphology, life cycle, pathogenesis, clinical manifestations, lab diagnosis and treatment. First, introduction. Intestinal amoebiasis is caused by an intestinal protozoan parasite called as I.AMOEBIA histolytica. It is most pathogenic. It is an intestinal amoeba and worldwide in distribution, but it is more commonly seen in tropical and subtropical countries. Intestinal amoebiasis is the third most common parasitic cause of death in the world after malaria and schistosomiasis. So we can see how pathogenic it is. So this Entamoeba histolytica exists in three morphological forms. The first is tropozoid form, precyst form, cystic form. Tropozoids are the invasive, feeding and replicating forms. These are found in feces of patients with active disease only. And precyst. Precyst is nothing but the intermediate stage between the tropozoid and the cyst. Next, third one is cystic form. Cystic form either mature or immature, means either it has 4 nuclei or not. If it has 4 nuclei, it is called as a quadrinucleated mature cyst. If it doesn't have, which means less than 4, it is called as an immature cyst. So this cyst is a diagnostic form found in the feces of carriers and active patients. So quadrinucleated cyst, as mentioned above, it is the infective form. Next, life cycle. So first we have to know about the host. It completes its life cycle, that is Entamoeba histolytica completes its life cycle in a single host, that is man. What is the infective form? That is mature quadrinucleated cyst. We have to know about mode of transmission, how it transmits. It mainly by fecal-oral route by ingestion of food or water contaminated with mature quadrinucleated cyst. Next, first life cycle. Man acquires infection by ingestion of food or water by contaminated with the quadrinucleated cyst. It enters the esophagus, it bypasses the gastric juice and reaches the small intestine. In small intestine, we all know that trypsin is released. This trypsin lyses the membrane of the cyst. So it undergoes excitation, and then the tropozoites are released. These tropozoites from the small intestine, they are carried to the large intestine, and these tropozoites colonize on the large intestinal mucosa. So from here, some of the tropozoites, mainly they penetrate the intestinal wall and are carried to extraintestinal sites. Most common extraintestinal site is the liver, where it causes liver abscess. And some undergoes encystation. They again forms the wall of the cyst, and they are released into the feces and mature cyst formation, and the cycle goes on, and a few tropozoites are released in feces and they are disintegrated. Pathogenesis. First we have to know about the virulence factors. There are 3 virulence factors: amebiclectin antigen, amoebia 4, cystine proteases and hydrolytic enzymes. Amebiclectin is the main virulence factor. It helps in tropozoid to adhere to the intestinal mucosa. Amoeba 4, it forms pores in the host cell membrane. Cystine proteases and hydrolytic enzymes helps in invasion into the GI mucosa. First, the tropozoites from the small intestine, where it released, they goes to the large intestinal mucosa. They colonize there. Next, they adhere to the large intestinal mucosa with the help of amebiclectin antigen, where it produces a characteristic flask-shaped ulcers, which means it has a broad base and a narrow neck. We commonly see flask-shaped ulcers in cecum. Next, these tropozoites invade the large intestinal wall and migrates to the extraintestinal sites and cause several complications. The most common site is the liver, no? So where it causes liver abscess. Next, this invasion is facilitated by cystine proteases and hydrolytic enzymes. Clinical manifestations. So first, incubation period. Incubation period varies. it is about 1 to 4 weeks. And 90% of all are asymptomatic cyst passes because they are not the active infected people, but they transmit or they helps in transmission of the disease. Next, 10% people only develop disease, and these are characterized by amoebic dysentery. So in amoebic dysentery people, they have bloody diarrhea, colicky abdominal pain and fever. This bloody diarrhea up to 10 times a day with mucus and pus cells. Next, other rare intestinal complications include there might be a intestinal perforation, there is a amoebic peritonitis, and amoebic appendicitis, maybe toxic megacolon, fulminant amoebic colitis, cutaneous amoebiasis. These are the rare intestinal complications. Lab diagnosis. First, what is the specimen of choice? It is a stool. Next, what is a stool macroscopy? So how it looks like by seeing it. And it is copious in amount. It is dark red in color, and it is mixed with blood and mucus. It is foul smelling. If you see in the container, it is not either into the container. Next is stool microscopy. By saline and iodine mount, we can demonstrate the tropozoites and cysts. So tropozoites, it measures 15 to 20 micrometer. It has a cytoplasm and a single nucleus. The tropozoites are actively motile because of the presence of pseudopodia. Here we can see. And the tropozoites are hematophagous because it in what we say, it ingests the RBCs. That's why. Next, the nucleus. So if we see the nucleus, there is a central karyosome and a peripheral fine chromatic granules, so looking like a cartwheel appearance. Next, quadrinucleated cyst. This cyst measures about 12 to 15 micrometers, and the cyst is round and has 1 to 4 nuclei. These nuclei after excitation are referred to as tropozoites. So this cyst contains few chromatid bodies and a large glycogen masses. And in stools, both mature and the immature cysts are found. Next, this is the stool microscopy. Next, we have to learn histology. So intestinal biopsies stained with periodic acid Schiff or H&E stains reveals tropozoites. We can see tropozoites after the stains. Next, stool culture. It is not routinely done, but if we do, the common media include polygenic and axenic stool culture media. Next, stool antigen detection, that is coproantigen. Various tests have been present to detect the antigens. Among those, there are two main tests, that is ELISA. It detects 170 kilodalton lectin antigen. And the second one is immunochromatographic test. It is a rapid diagnostic test. There is a triage parasitic panel. It detects simultaneously 3 parasitic antigen stool. That includes Giardia lamblia, Entamoeba histolytica or Entamoeba dispar, and Cryptosporidium. Next is serology, amoebic antigen and amoebic antibody. So the amoebic antigen and antibody both are detected by ELISA, and the amoebic antigen presence indicate an active infection. Amoebic antibodies are present in the serum against the lectin antigen. Molecular diagnosis, we all know gene detection, that is by nested PCR, real-time PCR or biofire assay. Array. Next, non-specific findings. So, if a person has a amoebic dysentery, there are some non-specific findings that includes moderate leukocytosis, that is a moderate rise in WBC count, and there are presence of Charcot Leyden crystals in stool. What are Charcot Leyden crystals? Means breakdown products of eosinophilics, diamond shaped breakdown products of eosinophils. Next, colonoscopy reveals flask-shaped amoebic ulcers. Next, what is the treatment? For the asymptomatic carriage people, luminal agents are used. Either idoquinol for 20 days or paromomycin for 10 days. Or amoebic dysentery. In amoebic dysentery people, luminal agents plus tissue agents are used. So same, luminal agents are same. Either idoquinol for 20 days or paromomycin for 10 days plus tissue agents. Those includes metronidazole for 5 to 10 days or tinidazole for 3 days. Others include fluid and electrolyte balance and symptomatic treatment. And prevention. So we have to avoid ingestion of food and water contaminated with human feces, and we have to treat the asymptomatic carriers. Hope you like this video. Thank you and subscribe.